symposium is sponsored by Sanofi. And it is my pleasure to introduce Professor Marco, who will talk to us about patient-focused approach in atopic dermatitis. Professor Ko is a dermatologist, pediatric dermatologist, and dermatopathologist. And he is a senior consultant in the dermatology department of Women and Children's Hospital. And he is a clinical associate professor at Duke NUS Graduate Medical School and adjunct associate professor at INT'L LKC Medical School. And he is a president of Asian Society of Pediatric Dermatology. He will talk to us about patient-focused approach in atopic dermatitis management.
Thank you, Dr. Samir, for the very kind introduction. I'd like to thank Sanofi for arranging for today's symposium. And I will be talking about the treatment of atopic dermatitis, mostly in children and adolescents, especially with the use of the dupilumab. And these are some of my disclosures. So as I said, I'm mostly a pediatric dermatologist. So most of my patients come to see me when they're children or adolescents, but I do follow them into adulthood as well. So today I'll talk about, firstly, the burden of atopic dermatitis and the pathogenesis and the role of Th2 inflammation. It's very important to understand, the role of Th2 inflammation so that we can treat our patients well. And finally, I'll talk about the role of the dupilumab for atopic dermatitis, mostly in the children and adolescents. So, atopic dermatitis, as we know, is really one of the most common conditions that we see worldwide. And in Singapore, we have seen patients, up to 20% of patients, children and adolescents, having atopic dermatitis, and up to 11% in adults. But I think more importantly is that we are seeing patients who have more severe and more chronic disease by the time they come and see us. And the prevalence is high in a lot of Asian cities, and in UAE, the latest numbers I found was between 11 to 16%. So it's almost the same as in Singapore. We are quite a high stress level. There's heat and there's humidity as well. I think importantly is to understand that most of the patients with atopic dermatitis, they start in early infancy, and then they get a little bit more severe in the first few years of life. And after that, they get better. And the good thing is, they get better naturally, right? And a lot of them respond to topical treatments. But there's a small group of patients, those in the red line, where they can get more severe disease as they go into older childhood, as they go into adolescence. And it's really these patients that we want to treat early and bring down their trajectory such that they then become much better when they go into adolescence and into early adulthood. So we now have a chance of really catching them early and really bringing down this trajectory. Otherwise, they go into this cycle of getting, worse quality of life and worse and more psychosocial issues, all right? So we know the comorbidities that are associated with atopic dermatitis. We already know the atopic march, itch, sleep disturbance, but now we know, and I'm sure in the next 10, 20 years, we will see more data on cardiometabolic conditions that are associated with the chronic inflammation in severe atopic dermatitis. We've already seen that with psoriasis, and I'm sure we'll get more data on this for atopic dermatitis. But what's important is that we are seeing a lot of patients with depression, anxiety, and suicide ideation, even in our adolescent patients. So it's important to treat them early. So even though atopic dermatitis doesn't kill a patient, but it really kills a lifestyle. It really kills the soul of a patient. And it's so sad to see a child, to see an adolescent being able to go to school, not being able to take part in games, not being to make friends and have social circles. And I've seen families who are disrupted because of severe atopic dermatitis in these children and adolescents. And so it's important, really to treat them early. This was a study that we did looking at the effect of childhood atopic dermatitis on the Singapore family. And you know that severe atopic dermatitis not only affects the child, but also affects the family. And that's why we really have to treat them fast. We have to treat them early. And in Singapore, everything is very expensive, but I just realized Dubai is even more expensive than Singapore, right? So in Singapore, it costs about $800 for a jab of dupilumab, but this study we did, we find that the more severe the patients are, right, they have to spend a lot more money treating the atopic dermatitis, and that's why you have to treat it early, treat it aggressively. Okay, so it's important to understand the pathogenesis of atopic dermatitis. We do know a lot about the epidermal barrier defect, and with the filaggrin mutations, the changes in ceramide levels. So this is still very important, and we always must emphasize to our patients, even when they're on biologics check inhibitors, they must still use their moisturizers, because it really helps to heal up that epidermal barrier. And with that disruption in the epidermal barrier, it triggers the immune system, firstly with the Langerhans cells, thermodendritic cells, which then leads to this immune activation of the Th2 and Th22 pathways. And we know very well that Th2 cells produce IL-4, IL-5, and IL-13, which triggers all the inflammation that we see in atopic dermatitis. And now we also know that there's this crosstalk between the epidermal barrier as well as the immune system. And it's so important really to treat both, because if you only treat one part of this, the other part doesn't get better. So we know a lot about Th2 inflammation in atopic dermatitis. The Th2 cells produce IL-4, IL-13, and IL-5, and this then triggers recruitment of other immune cells, in particular more T cells, more Th2 cells, which then go on to produce even more cytokines in the Th2 pathway, and really, keeps the eczema severe. And not only does it have an effect on immune cells, right? So it triggers mast cells, Th2 cells, but it also causes itch sensitization. They found that itch worsens with Th2 inflammation. There's an increase in IgE and eosinophils. We're not 100% sure how that influences the atopic dermatitis, but we do see that increased IgE and eosinophils as well. But also we see that there is this effect on the epidermal barrier, not only on the skin, but also in the airways. And a lot of our patients have allergic rhinitis, nasal polyps, as well as asthma because of this Th2 inflammation. And this slide emphasizes the fact that not only does it have local tissue inflammation, but also systemic effects, whereby other immune cells are brought in, but also other effects on the skin, whether it's microbiome, mucus production, barrier dysfunction. All this are all in a very close interplay with each other. All right, so now what are the Th2 diseases that we see in the different organ systems? Of course, on the skin, we know very well atopic dermatitis, but there's more data now out on the use of Th2 inflammation in chronic spontaneous urticaria, and I just heard that dupilumab has been approved for the use of CSU. Prurigo nodularis also responds, so there are patients that have treated just purely prurigo nodularis without atopic dermatitis. They do respond to dupilumab as well, and now there's some data on bullous pemphigoid as well, quite a few studies coming out. Of course, on the upper airways, we have the chronic rhinosinusitis with nasal polyps, allergic rhinitis, and on the lower airways, asthma as well. And we do find that when we treat patients with dupilumab, their asthma gets better, the allergic rhinitis gets better. And I think importantly for the children, we are seeing increased food allergies in our younger patients, and we do find that with treatment with dupilumab, their food allergies actually get better, and the parents come back and tell me that the child is able to eat eggs, the child is able to eat peanuts again, right? So it even works on food allergies. So this, again, emphasizes the fact, that Th2 inflammation plays a huge role in atopic dermatitis. Of course, I think, really atopic dermatitis and psoriasis is really on a spectrum, and with one end where you have a lot of Th2 inflammation, and on the other end, a lot of Th1. But I think there are a lot of patients who lie sort of in between these two ends of the spectrum. But in pediatric patients, they found that Th2 plays a much bigger role compared to Th1. In adults, sometimes there are patients that have a bit more Th1 compared to the children, and that's why the response in kids is better to dupilumab compared to adults. And I was talking about, the barrier dysfunction, type 2 inflammation, neuro dysfunction being really, interrelated, and you really have to treat all these three in order for all three components to improve. So you can see here, type 2 inflammation really causes skin barrier dysfunction, and not only in the skin, but also in the airways, the lower airways, as well as the upper airways. So it's very important to control that Th2 inflammation. And we do know the skin barrier plays a huge role in atopic dermatitis, and really when we don't control the Th2 inflammation, the filaggrin levels drop, ceramide levels worsen, and the epidermal barrier worsens as well. So it's important to treat both the Th2 inflammation as well as the epidermal barrier. And now we know also that Th2 plays a large role in itch in eczema, right? So, antihistamines really don't work very well in atopic dermatitis patients, because histamine plays a very, very small role in patients with atopic dermatitis, and generally you have the other cytokines like IL-4, 13, and 31 playing a big role in the itch in eczema patients. And that's why this slide as well shows you that histamine plays a role mostly in acute urticaria, but in chronic conditions such as eczema, you have a lot more cytokines that causes that itch. And that's why dupilumab really, really helps with the itch. And that's one of the things that patients tell me whenever I start them on dupilumab, is really that the itch improves very, very fast. So this slide really summarizes the interplay between Th2 inflammation, the skin barrier. All right, so Th2 inflammation is central. It affects the skin barrier, but it also worsens the itch, and there's also effects on the microbiome, and that's why you really have to control that Th2 inflammation. All right, so the role of dupilumab, it's an IL-4, targets IL-4 receptor and blocks both the IL-4 and IL-13 signaling and inhibits the entire Th2 pathways, first approved by the US FDA for adults in 2017, and now it's gone all the way down to 6 months of age. So it's safe to treat from infants from 6 months of age. This was the very first study that was out on, for adults with atopic dermatitis in 2014, so it's been around for almost 10 years now. Very good safety data. So the initial study was for 4 months. This is the longer-term study, and you can see that the initial improvement, usually you get it in the first 4 months, and subsequently, that improvement is maintained as you go on to 1 year of treatment. And then the studies for the adolescents came out. This was a study that was in 2020, looking at 12 to 17-year-olds, and you find that with treatment with dupilumab, there's improvement in objective scores, EASI-75, IGA, as well as in subjective scores, the PP-NRS, the CDL-QI, as well as the POEM score. So not only is there objective improvement with dupilumab treatment in the adolescents, there's also very good subjective improvements. In terms of side effects, almost similar to the adult side effects, so we do see there's a small proportion of patients that get conjunctivitis, as well as injection site reactions. And this was the study, the longer-term study up to a year. You can again see that there is good improvement in the first 4 months, and this then carries on. And you do find that even those patients that don't have as good improvement at 4 months, if you continue, they can improve some more. So it's important to continue for at least a year when you treat them with dupilumab. Right? Again, the longer-term studies, the side effects, again, conjunctivitis, injection site reactions, very similar to the adult studies. And of course, they brought the studies down to the 6 to 12-year-olds. And again, similarly, you find that good objective response as well as good subjective response compared to placebo. So the itch, quality of life improves so much in the first 4 months especially, but after that, it can continue as well. This is the CDL, the quality of life improvements compared to placebo. Again, side effects in the 6 to 12-year-olds, very similar to the adults. Again, conjunctivitis, injection site reactions, but not very common, all right? And this was the longer-term study. Again, you can see the good improvement in the first 4 months, and this is maintained. And in fact, some of them do even get better as you treat them longer than the 4 months. Long-term side effects, very similar, conjunctivitis as well as injection site reactions. This was a study down to 6 months of age, so safe in infants from 6 months of age. Very similar effects compared to the children as well as adolescents as well. So again, very good improvements in the first 4 months, both in terms of objective as well as subjective scores. So just some sharing of some of our patients. This was one of our earliest publications that we did. This was, when we started, we gave to the adolescents first because we were not so comfortable giving to the children. So this was a 16-year-old that had very severe eczema. His EASI was 60.1, and you can see that after 4 months of treatment, it's gone down to 10, but as we continued, this improved even more. This was a darker skin patient, and sometimes in darker skin patients, you don't see so much of that redness, but he has severe itch, EASI of 64. After 4 months of treatment, you can see EASI has come down to 25. So probably he got about between EASI 50 to EASI 75 improvements, but if you continue on, he does improve even more. This was a slightly younger child that had undergone phototherapy, but really not much response. EASI 44 to start with, and you can see, it goes down to EASI 6.4. Her life has really changed. I've got pictures of younger kids. You can see EASI 22.6, and after 4 months, down to EASI 2. This was a child with underlying immunodeficiency that had GED kind of presentation, and we treated with dupilumab. EZ of 62, and improved to EZ of 5.6 after 4 months of treatment. Very safe, even in some of these immunosuppressed patients that we treat together with our immunologists. So our experience, we treated more than 300 pediatric patients now in our hospital. The youngest is about 1 year of age, longest duration between 6 to 7 years now. So that's the dose that we use for patients. We mostly give them loading dose of 600 milligrams, that's 2 vials, and subsequently we give 300 milligrams every 2 weeks for the slightly bigger kids, 30 to 60 kilos, we give 3 weekly, and less than 30 kilos, we give 4 weekly, the 300 milligrams dosage. I would say most patients will get at least EZ 50 after 4 months. There are some patients get EZ 75, but there's a proportion of patients that even go up to EZ 90, and we're seeing even EZ 95, EZ 97. But we see that the most significant improvement is within the first 4 months, but maximum improvement at 1 year. What happens after 1 year? We try to reduce the frequency because of the cost, but there are some patients that still want to go on it, so we slowly increase the frequency between the sessions, between the injections. When you're switching from systemic immunomodulators, we usually overlap for 1 to 2 months. For those suboptimal responders, think of other confounding dermatosis. Do optimize your topical treatments or consider adding adjunctive therapies. I do get questions about JAKs together with dupilumab. I should be done in about a minute, yeah. So in terms of monitoring, for the kids, very safe. We started out doing some monitoring, but now we've stopped doing that. So we don't do any pre-dupilumab bloods or monitoring bloods. In terms of safety, we do see some mild conjunctivitis. So it usually occurs in patients with a history of allergic conjunctivitis. So we do have a low threshold to refer to our ophthalmologist and manage them. But what we found quite useful is to start them on concomitant prophylactic eye drops, a bit of tears natural, in the first few weeks when they start on the dupilumab. So in conclusion, I think atopic dermatitis really is so common, and we are seeing more chronic, more severe disease. And really severe disease can, when poorly controlled, lead to really severe psychosocial impairment, and we really, really want to treat them early. And now, with the biologics, with the JAK inhibitors, we really, really want to start treatment early. We shouldn't be seeing severe atopic dermatitis anymore, in our older patients, because we want to catch them early,
Thank you, Dr. Mark, for a very informative presentation. The floor is open for 2 questions. Yeah, Dr. Salah, please.
As you know, IL-23, Thi-27 is the main pathway. IL-23, Thi-37, you can hear me?
Yes, I can hear you.
Yeah.
IL-23.
This is the main pathway. If we block it early, this gives better prognosis. And my second question about the innate lymphocyte 2C. If we block it early, if we block, for example, thymixtrom lymphoprotein or IL-33 from keratinocyte, it can give better...
So I think the first question was on the IL-23 pathway, IL-22?
Yeah, IL-23 and you know, this is the main pathway.
And TSLP?
Yeah. If we block it early, for example, if we block IL-23, is it superior than to block for, it's not?
No,
there is comparison study about that.
No, so we don't use the IL-23 blockers for atopic dermatitis. We find that there's no studies on it, so it's not so useful. I think the question on blocking TSLP, studies, there are not much studies yet, but I think in the future, those are targets as well.
Second question, Dr. Hussain, please. And last question. Yes, please.
Adolescent age or pediatric age, this is not the dose in our leaflet here. And I do believe that your dose is more effective than ours. And I do pledge people of Sanofi to do something about that. My question is about, there is a very recent study comparing dupilumab and one of the JAK inhibitors, and the primary endpoint was EZ90 plus complete relief of itching, the numerical rate scale of 0. Do you have any comment about this study?
Okay, thank you. Very important question. So the first question about the dosing that we use. So in Singapore, because a lot of patients have to pay out of pocket, or sometimes they have insurance payment, The 300 and 200 milligram vials are the same price in Singapore. And if you know Singaporeans very well, when we spend money, we want to get as much as possible. So they'd rather pay that same amount for a 300 milligram vial than a 200 milligram vial. So sorry about that, Sanofi. And that's why it's always on my slide. The other good thing about our dosing is that because you're treating kids and it is a subcutaneous injection, they would rather do one jab every 4 weeks than one jab every 2 weeks. So you get better compliance. And that's why we have decided to use this regimen. You can try. I'm not sure about the reimbursement here, but I'll let Sanofi deal with that. And your second question is on JAKs versus dupilumab. Okay, so there are now studies comparing JAKs with dupilumab, and I do find, so we were on the trial for upadacitinib, we were also on the trial for lebrikizumab, and I do find that the JAKs, the response is faster. You can see that they can get faster response compared to dupilumab, and the effects can be more robust. And as you said, you can get EASI 100, EASI 95 very easily with the JAK inhibitors. But when you stop the JAK inhibitors, the recurrence is faster than with the biologics. We were on the upadacitinib trial, and it went into COVID, and they couldn't get the medications. They all flared up within a few weeks. So there are benefits and downsides of both treatments. I think in terms of side effect profile, I would think that the biologics would be more safer, and because we are treating children, we do have to think of the long-term side effects. So if I had a choice for my own kid, and my own kid, I gave my child dupilumab initially, but then she didn't like the jabs, and so I had to switch her to abrocitinib subsequently. But I seriously think if I had a choice, I would rather the biologics compared to the JAKs. But the important point is we have this new armamentarium in the last decade.
Thank you, Dr. Park.
That's so important.
Actually, because of the time, we have to end this session and to continue for the next
Okay, thank you, Dr.
session. Thank you.
Thank you.